Good afternoon. I'm Raxana Colman-Herak, your host of Good Medicine. Today we have two guests that I think you're really going to enjoy, and certainly you will learn a lot from some of the things that are happening in our community to try to thwart the problems that we're having with prescription medications. Our guests today are Leah Emerson from the St. Luke's Community Hospital and Clinic, and we also have Hikmat Maaliki, who is also a physician with the St. Luke's Hospital and Clinic. So let's start this off. I mean, I want to make the most of this time that we can. So let's talk about some of the policy changes, what you're seeing in the hospitals as far as prescriptions, what's happened, how did this all evolve, and let's just open it up for some dialogue.
Okay. Well, this has been a long process that's been building. Statistics that come from the CDC show that between the late 80s and the early 2000 and about 2010, there's been a fourfold increase in the amount of prescription drugs. We're talking specifically here about opiate painkillers, narcotic prescriptions. And over that same period of time, there's been a fourfold increase in prescriptions and a fourfold increase in deaths due to overdose. So this has been a problem that's been building for some time. And what we see globally, really across the United States, but it is higher in some places, and Lake County very specifically is a bit higher than some of the surrounding areas, is an increased risk of use, misuse, and abuse of these medications with an associated rise in the rate of death from these drugs, overdoses, both intentional and unintentional.
Are you seeing a lot of you work a lot with the nurses. In fact, you're the director of nursing. So what are you seeing in the emergency rooms? Are you seeing a specific age group that is maybe experiencing some of these overdoses? Globally, what are you seeing?
I think the problem extends across all age groups, and certainly we are seeing it in younger and younger individuals as well. But we see it with male, female, younger, older. Prescription drug use has just become pervasive. And in the emergency room, we see an increased number, as Dr. Maaliki said, over the last 20 years, of people who are there specifically seeking prescription medications and narcotics. Because, at that point they've developed a need, whether that's psychological or physical dependence. But we're seeing increase in that steadily.
So what are some of the policies? I mean, what is the hospital considering doing to maybe address this growing concern?
Well, so in response to this very real issue, in fact, St. Luke's Hospital and the clinics associated, we have just in the last month passed new policies. We really have two policies, but they dovetail together. So one of the policies that we've implemented in the hospital is from the emergency room in our walk-in clinic, which we call convenient care, which states that when individual patients present to the emergency department with essentially the sole goal of acquiring narcotic pain medication, that they can't give it to them for outpatient use. They can't give them prescriptions, because we had a really high number of people who would present to the emergency room for that purpose, excuse me. And so if people have acute pain, if they have a reason to be treated for pain, they can be treated for that pain. Certainly for people who have acute injuries, acute pain, we're separating this out from chronic pain medication use. Those people get treated like they always did. And even if you do use chronic narcotic pain medications, you can still be treated acutely for a problem, but you can't be given a prescription to go home with. Because this is one of the ways that people manipulate the system. And on the clinic side, we've implemented a policy now that anybody who is taking chronic narcotic pain medications, and chronic is defined as use of these medications for greater than 3 months, then they have to enter into a contract with their provider. They can only get these medications refilled from their primary provider in that clinic setting. And we've had to create a lot of rules about early refills, because we have a number of people, whether it's accurate or inaccurate, who represent saying, I ran out of my medications were lost, my medications were stolen. And we hear these lines every day, and unfortunately, sometimes it's true and sometimes it's not. But we've had to implement policies that we will not be giving those out to replace early. And then now we're encouraging all of our providers to utilize a service that's provided by the state. There is a prescription drug registry that's online right now. And that allows us to be able to see if people are going to multiple sites, multiple providers to get prescription medications. And if we identify that kind of behavior, then we can address it appropriately.
So what, with the situation today, we've had law enforcement on this program, and we've had a lot of different people talking about the concerns that are happening with prescription pills. And there seems to be, unfortunately, a market out there where people are selling their prescriptions or whatever they do. It seems to be a profitable business sometimes. So how does this all tie into why this policy was developed? I mean, I know that there's a problem with drugs on this reservation in every community. So how is this going to impact someone? Let's say they come in, they get a prescription, and they become addicted to this prescription, and then all of a sudden, after 3 months, it's time to start stepping them down. Are there services in place to be able to address that gap? Because I know that's been a very wide gap for years. Now we have addicts that are addicted to prescription drugs that they had a prescription for.
Right, so this is another area. The treatment of pain has evolved into a medical subspecialty in and of itself. We do recognize that there are people who have true chronic pain. However, it's not entirely clear how to address this. There are varied strategies. In reference to the question you had about taking people off of these medications, Montana unfortunately suffers a dearth of appropriate substance abuse counseling and treatment resources. It's a very, very stressed resource in the state, and we have a very difficult time. And this is an area where, unfortunately, it would be nice if we could do better, but it's hard to fund these programs. It's hard to fund people getting into them, especially if they don't have the financial resources to get into these programs, which can often, if you need to be treated in an inpatient setting, can run 1 to 2 months in length if necessary. The treatment of chronic pain also involves multiple modalities, and one of the modalities is narcotic pain medication use. Through well-structured programs, using there are appropriate screening tools that can be used. Some patients can be risk stratified in what is their risk of abuse and addiction behavior. And then those individuals can be counseled to try other forms of pain medication. That being said, there are some people who do benefit from these medications if they're used correctly, but they have to have realistic expectations of what's going to happen. And an unfortunate byproduct of these medication use is that inevitably, if you use them long term, you will become dependent upon them, meaning that you will experience a withdrawal syndrome if you don't take it. That said, if you maintain a stable dose, you won't go into withdrawal. And people who use these medications appropriately accept that there is some pain in their lives. They cannot make their pain go away forever, because the tolerance that develops with these drugs also means that eventually the same dose won't work. And so people need to have a realistic expectation that the purpose of this treatment is to help you move around, help you be functional. But you can't expect to be pain-free all the time. That just isn't going to happen.
The other thing, Roxana, in response to your question, is that the policies that Dr. Maaliki is referring to in the emergency department and convenient care in the clinic that kind of go together, one of the purposes of those guidelines, and this policy really is a set of guidelines for providers and physicians, is to help steer that process toward the patient's primary care provider. So if one individual is aware of what's happening, understanding what the patient's needs are, and able to communicate and educate that patient, then there's a better chance that this is well managed, and that somebody's keeping an eye on it and understanding what's happening with the patient's progression. Whereas if it's very uncontrolled and that patient is going to many different providers and many different pharmacies, that's an area where things are much more dangerous.
And so that's one of the things that you're going to be able to manage more directly. For instance, if someone goes to, we'll say, Missoula for a prescription of something that they just received a prescription for here 10 days before, that would show up and send a flag that this individual is seeking medications outside of their prescriptive dose.
Correct. And in the clinic guidelines, patients who want to work with their physician on this and make sure that they're communicating well, they actually have a contract with the physician that says, if I go to some other physician or I have another problem someplace and somebody prescribes something for me, I'm going to let you know about it. I'm going to tell you so that it can be part of the entire picture of what's going on. So that communication between provider and patient is going to be critical.
So what's the difference? I mean, there's a lot of people, I mean, we work with suicide prevention, and always the common thread with someone who becomes suicidal, and that can be also because they stop taking medications or their medication's not quite right for them. So if we think about that, what can an individual do to better manage pain, whether it's emotional, whether it's physical? Life brings pain.
Right.
That's the reality.
So an example that a lot of pain clinics use, unfortunately we don't have a pain clinic in Lake County.
Think we ever will have one?
That's hard to say. Specialty clinics require a certain volume of patients to make it feasible for them to operate. I would envision that perhaps before we would see an actual pain clinic, we would see maybe a satellite of a pain clinic from a neighboring county, where maybe they would make periodic visits and run a clinic locally. That would be more likely to happen in the near term. But one of the things that these pain clinics do is they have a very structured program. Before they start prescribing you control medications, they do screenings to evaluate, what is your, first of all, how bad is your pain? How do you manage your pain? How do you perceive your pain? Do you amplify your symptoms? Do you make your symptoms out to be more perhaps than they are? They look at what is your risk of abuse and risk, or potentially your risk of diversion, meaning sending your drugs elsewhere, selling them or whatnot. And then the other thing they look at is they have a structured psychological program. A lot of these programs you have to meet with their pain psychologist first, because part of the management of pain is the psychological, emotional ability to deal with it. And so this is how pain clinics, where they use the most up-to-date evidence-based formats of treating pain, this is how they run. And so that's one of the benefits of programs like that, is they have more structure to them.
I really hope we can see something like that. I know that this is a growing concern. I know there's groups that are meeting as we speak, probably trying to figure out a way to address not only the prescription drug problems that are growing, but also the illegal drugs, meth, some of these other things that are in our community. What are you seeing as far as the emergency room, as far as illegal drugs and overdoses, suicide attempts?
I think by and large what we're seeing is meth more than anything else. I know that obviously other street drugs are available to folks, but meth probably is the largest concern for us in the emergency room. I think that there are a number of factors that go into patients who we see with suicidal ideation, serious depression, those kinds of things. And again, in Montana, we have less resources for folks, although I think in Lake County we've worked really hard to have some additional resources available, a counselor on call all the time so that we can reach somebody in a crisis situation. And there's more efforts going on within the county as we speak to try to address that situation. We will certainly, keep patients in the hospital with us overnight to make sure that alcohol is not playing a role in their thought process and their decision making at that time. In the clinic, we're adding a licensed clinical social worker who can help physicians address this issue in the clinic with patients through interview techniques to determine a willingness to make a change, to move forward to address some of the issues that are going on in their lives. So, I think probably more than ever in the last maybe 5 to 10 years, we have things moving forward. And it's not going to change overnight. It's not going to address things immediately, but I think we're headed in the right direction.
Yeah, I think another thing to add to that is that a lot of these drugs that are used, for example, the illicit substances such as methamphetamine and the controlled substances such as the narcotics are used in conjunction together. And they're not always used in suicidal attempts. In Montana, the prescription drug overdose death rate is higher than methamphetamine, cocaine, heroin, and I believe the statistics also cite vehicular deaths and homicide all combined. So, these are drugs that are used differently. People perceive that there's a safety to them. Yeah. I think an interesting historical fact here that people don't recognize, because it really is pertinent today, but heroin, everybody thinks of heroin as this really horrible drug, but when heroin was first synthesized, it was synthesized as a non-addictive substitute for morphine, because back in the 19th century, they saw that people were displaying addictive behaviors with morphine. Same thing they saw with opium, as morphine is synthesized from opium. So a pharmaceutical company actually synthesized heroin for a non-addictive substitute for that. That backfired horribly. So these drugs have always come with this risk, but people have a perception that they're safe because they're prescribed, but they're not safe when they're not used correctly.
Are you seeing a younger and younger group in the emergency room as far as medications? I mean, we certainly know, and I know the officers have talked about, between 15, 14, I mean, the earliest use that they were aware of is that there was an 11-year-old who was addicted to meth. I don't know how we can stress the importance of how volatile and how highly addictive methamphetamine is at any age.
Drug use is such a complicated social issue. That certainly would go beyond, I think, what we can talk about in this talk right now. The problem is multifactorial. I mean, we have young people. We have what they have exposure to. So increasingly, there are prescriptions in the house because parents or other members who live in the household have these medications. In addition, they have peers who have access to these medications, and it's very common now to experiment with these medications. This is in addition. It's all risk-taking behavior. Yeah. Young people readily engage in risk-taking behavior. So we see it. We view it all kind of through the same lens, right? We view it as inappropriate use of a substance, regardless of the DEA categorization of these medications. If they're habit forming and they're used inappropriately, we have a problem. And in general, and the other place where we see it's the same problem is alcohol, right? I mean, alcohol just carries a very different legal status, but I mean, we have a tremendous problem with alcohol use.
So, taking all of that into account, now let's say we know that there's probably a lot of medications in homes, and I know there's some safeguards out there of what people can be doing to try to not let these medications into the hands of people that they're not prescribed for. And I mean, just in common conversations, I'll hear people say, I gave so-and-so one of my pills because I couldn't get in to see the doctor, and it was the same pill, but still, can you speak to that?
Yeah, so technically that's actually illegal. To give a controlled substance to another individual without a prescription is actually, frankly, illegal. We get a lot of reports like this, and I try myself, and I think I can speak for my colleague, we try to impress upon people that that's not appropriate to do. We try to encourage people that, look, these medications, they're dangerous. They're also highly valued on the street. There is a fair amount of crime that occurs with people having break-ins and thefts. But ultimately, these medications are your responsibility. You need to lock them up. So a lot of people will eventually get lock boxes, other ways to protect to protect these medications from getting into the wrong hands. Oftentimes this happens after they've been robbed. They will make this decision. In addition, at the state level, the Attorney General has a program. They've instituted a lot of programs for how to safeguard your home, how to safeguard your drugs, what to do with your drugs if you don't even want them anymore, how to in give back programs. And
Can you talk about that a little bit more?
Yeah, so they have a website. The Attorney General has a website for the state of Montana, and I don't have that website off the top of my head. But that if you went online to a browser and looked up Department of Justice for Montana, and you could plug in prescription drugs. So it's titled Silent Epidemic, and there's a line of places you can go to within that website. So what are they doing? What are some of the statistics? And what are some of the programs they put into place, such as give back programs where you can go to law enforcement and give them your medications that you're no longer using, and then law enforcement disposes of them appropriately. A lot of people think that flushing their medications down the toilet is a good idea. That's actually not a good idea. It actually contaminates the water supply. This eventually gets into our waterways, our rivers and fisheries and lakes, and actually is not the appropriate way to get rid of medications. So there are a number of things that they're trying to do at the law enforcement level and the state level in terms of trying to safeguard this excess drug supply.
Can you talk a little bit about when someone is prescribed medication, how long does it actually take to start working in the system? Let's say I came to you and whatever my condition was, you say I have to take this for 30 days. Why do I have to take my medication for 30 days?
So are you referring to pain medications? So we would typically, we would rarely prescribe medications with that kind of, medications are rarely prescribed, say you take this for 30 days and then you stop. Oftentimes the way these medications are initially prescribed is that there is an acute injury, something happens. You have surgery, you have a broken bone, you're in a motor vehicle accident, you have some kind of an injury, and you present with acute pain. And so at this point, a prescriber will prescribe you medications, oftentimes say, use this medication as needed for, anticipating that this pain syndrome will resolve, because most of the time acute pain resolves within a matter of days to weeks, and most individuals will just stop taking the medication as they cease needing it. But some individuals will
Let's
use
use depression, because I know this comes up a lot,
Mhm.
and before it can actually, after it's introduced into the body, what I'm told is that it can take time for this to stabilize within the body, and that could be just hearsay, so that's why I'm asking you.
Oh, well, the medications work actually rather promptly. They work very quickly. So you will get immediate pain relief with them, and that will work very well. But then what happens over time is that you will develop a tolerance to that drug. So we are all physiologically programmed to develop tolerance to opiates. We have an internal opiate system we call our endorphin system. And that endorphin system is how we respond to pain and stress. But when you take opiates chronically, then what happens is that your body turns down that system. It's getting plenty of opiates from outside, so it turns off its own internal system. And when that happens, we call that tolerance. And then what happens is that the same dose that used to give you relief doesn't work anymore. And this develops over days to weeks of usage. And then what will happen in some cases is that people will start to experience that they feel poorly when they don't take it. And that's what we call withdrawal. In that case, these people have developed dependence, which is also a natural physiologic response to these medications. But now they'll start taking the medicines for the wrong reason, right? Now maybe I don't feel so good, but I know that if I take my medication, I'll feel better. And that's not the right use for that medicine. But this is how that cycle of dependence escalates. And when that happens, you've kind of crossed the line into overuse of medication. And that can happen within weeks generally. So that's part of what we as providers are trying to do is try to identify when this is happening. And there are some patterns that we can see if we're looking for them. And part of this requires training and understanding what signs to look for. And this is part of where, as medical societies across the country, we're trying to have more training so that providers, as they come out of their training programs, are already clued in for what to look for.
I think it's really important because you're talking about you're talking about education. This is like not just for providers. This is an education where we kind of all need to be more informed about prescriptions. You know, if they come, every time you get a prescription, there's always these sheets of paper that kind of tell about the prescription. I don't know how many people actually read those, but I think this has been really helpful, and certainly it's helped me to better understand what prescriptions are, what they do, and going from there. You were going to say something.
Well, one of the things I was going to mention is that I think, as Dr. Maaliki talked about the progression and the way that people become dependent on it, one of the things that we as medical providers have to recognize is that people truly still have pain.
Yeah.
And that pain may be physical pain, it may be mental pain, it may be depression, it may, you know, but they have a discomfort, which is why they're looking for this medication. I think the challenge for medical professionals is to educate, as you said, parents, patients, whoever, to understand that narcotics are not the answer to that pain, that narcotics simply keep the merry-go-round going, and you can't get off because the problem continues to perpetuate. And so there is a need to have some sensitivity to individuals to understand that, you know, that we recognize that you have a need and that you have a discomfort, and we need to find a way to address that. But narcotics may not be in your best interest. And that's a difficult thing for some folks to hear, you know, because that's, they've become dependent on it. That's something that they see makes them feel better. And so it's not always a message that's well received. But at the same time, it's an important message to say, we care about you, we care about what's happening, but narcotics really are probably not the answer, at least not long term.
Well, there you heard it. That's the conclusion of our program today. I hope this has been helpful for you. I hope you will take this seriously, and maybe there's some other ways that we can all find ways to live healthier, better, happier lives. Thank you. Thank you, Leah. Thank you, Dr.